Hi, everybody. This is Dr. Alexander. Hope you're all enjoying your snow day. Although it seems to have melted, I'm recording this. It's about 2:30 this afternoon. I feel like I haven't seen you all in forever, so I'm excited to finally get back in front of you next week when we meet next Friday. I'll have a new edition when when I come back in. I will be sporting a bright blue cast and either crutches or a knee scooter. I had a fall this past weekend and actually ended up breaking a bone in my leg, so I will be on limited use of my right leg for the next 6 weeks. So anyway, that's I have things propped up, and I'm definitely implementing the rice and using non-steroidals. So I'm using my non-prescription drug products here quite a bit. But anyway, this week we're actually going to talk about acute illnesses. Luckily, none of the kind that I'm suffering from, but other acute illnesses that you'll probably commonly see in pharmacies. Um, Oops. So this narration is just going to go along with the slides that I have posted. If you look at our objectives, it's very, very similar to what we cover every class. We're going to talk about different assessments for three key acute illnesses. Next Friday's lecture will actually cover three additional acute illnesses, and there's some relationship between the different ones that comprise these lectures, but they're not necessarily bulky enough to stand on their own, so we just kind of combined them. We'll talk about patients who are not candidates for self-care, who need referral, talk about different commonly used agents, how to develop regimens, specific counseling points, and then non-drug measures to recommend as well. So the first acute illness we'll cover is fevers. So what is a fever? Oh, and if backing up to slide 3, if you haven't seen the SNL skit with Will Ferrell, you need to Google the Blue Oyster Cult skit. It's my favorite, and you'll understand why it's on my fever slide intro here. So anyway, what constitutes a fever? Well, a fever is any body temperature higher than your normal core temperature, which is typically right around 100 degrees. Specifically, it's 100.4 degrees. Most fevers are self-limiting and non-threatening. They're just an underlying symptom that something might be going on in the body, some sort of larger process, whether that be an infection. In some case, it can be malignancy or cancer. Sometimes it can be drug-induced. And so really it's the way of your body letting you know that something's going on. And you probably want to sort of look into that underlying process to figure out how to resolve it to ultimately resolve that fever. Normal body temperature ranges a little bit, and it can actually range throughout the day. You will commonly see people have a higher temperature at night and a lower temperature during the day, and everybody's body temperature is slightly different. There are at night meaning in the late afternoon. So there are a couple other definitions for body temperature. You may have heard of hyperthermia or hypothermia, probably more commonly. So hypothermia is a low body temperature. Hyperthermia is a high body temperature that can be dangerous. And these are at temperatures up around 106 degrees Fahrenheit. At that point in time, you can have pretty severe damage from those kind of high temperatures because patients are going to be incredibly dehydrated, and can also result in things like seizures, coma, and damage to the neuromuscular system. So we do look closely at fevers just because if they are untreated and allowed to go very, very high, that can be very, very dangerous. We already talked that there's lots of different causes for fevers, and they're basically your body's way of telling you that something's going on. Although the large majority of them we really don't know. It's idiopathic. We're not quite sure what's causing them. Of the ones that we do know are have a root cause, microbial infections are probably the most common. There are also some non-infectious processes as well. As I mentioned, malignancies. Sometimes if patients have a hypersensitivity reaction or an allergic reaction, you may see an elevated body temperature. If they're dehydrated or they have some sort of inflammation in their CNS. You can also see it with tissue damage, including when you break a bone, or if you have some sort of surgery or a heart attack. And then also you can see elevated body temperatures in metabolic disorders like hyperthyroidism or gout. There's several different medication-induced causes of high body temperature. And if you want to see a full listing, it's actually in your book. But basically, you want to discontinue that drug in collaboration with the practitioner because it may be due to some sort of sensitivity reaction. And again, you just don't want to have that elevated ongoing. Typically, you'll see elevations in temperature about 7 to 10 days after the administration of the affecting drug, and they'll resolve within about 24 to 72 hours after you have stopped that offending drug. It's very, very common with vaccines, for example. So signs and symptoms. Honestly, some people don't even realize they have elevated body temperature. It can be very nonspecific and sometimes asymptomatic. You're probably going to see fewer symptoms in older adults because the elderly patients have a decreased perception of thirst, as well as changes in their ability to perspire, so they're not going to sweat as easy. Fevers are generally more heavily reported in children, but usually kids tolerate fevers very, very well. So we'll talk about a little later that if the child is asymptomatic, it's not necessarily a reason to treat that fever if it's mild or low grade. In general, patients may complain of some accompanying symptoms, things like headache, sweating, just feeling generally tired, having chills, and then more rarely things like increased heart rate or tachycardia, arthralgias or joint pains, or muscle pains, myalgias, irritability, which is very common in children who can't express what's going on, or just not wanting to eat. There are some complications of seizures. One that's specific to children is called febrile seizures. This actually happened with Dr. Burchett's little girl a couple months ago and was very, very scary. It occurs only in about 2 to 5% of children, and they're very young, so about 6 months to 5 years, but you'll see it in peak around a year and a half. And her daughter was about 1 year old when she had her febrile seizure. But there's various risk factors that can increase that, and it's again due to a viral underlying cause. So when we assess temperature, there's lots of different routes that you can check temperature by. If you remember when you were a kid, your mom probably put her hand or the back of her hand up against your forehead to feel if your skin was warm. And while sometimes you can tell, generally warm to the touch is just too subjective. It's not going to give us a good enough reading on exactly how high the body temperature is. So we typically have to come up with a thermometer measure to figure out what the actual core body temperature is. There are several different routes, and I'm going to go through them right now. In general, the rectal route is the gold standard for children under 6 months. It's really the best way to get at core body temperature anyway, which we'll cover on slide 9. But unfortunately, most children, once they're able to talk, and especially once you grow into adolescence and adulthood, really don't want to use the rectal route to assess their temperature. So that's where you run into patients switching to oral route, temporal route, which is right out along kind of the side of the face, or the tympanic route, which is using infrared ear scanners. They're all slightly different in terms of accuracy. Most of the time, it's heavily reliant on technique. So if the caregiver doesn't use the appropriate technique, in where they place the thermometer, they're going to get an abnormal reading, and it's going to impact the accuracy. So when would we maybe want to steer away from some of these different routes? Well, it's basically any time that something is going to impede accuracy. So if you think about it, times you may not want to use the oral route for measuring temperature would be if the child is hyperventilating. So if they're crying uncontrollably, if they're breathing in and out, that's going to really interfere with your ability to get a really good reading. Sometimes too, if you have people who have been eating or drinking hot or cold beverages, again, that could potentially change things, or even be smoking. And then vigorous physical activity can also change and cause oral temperatures to be less accurate. As far as tympanic measures, we definitely think of this if there's any sort of earwax, or if they have any potential for an ear infection. Now, this is tricky because the first sign of an ear infection may be fever, but generally an ear infection might make that route a little less likely to be accurate. Axillary temperatures are where you measure using a thermometer under the armpit, and those are typically the least accurate. They're generally not recommended, and any arm movement, again, can throw that off. So moving on to slide 8, here's some photos of how to assess temperature. And so we're going to start kind of from that upper left and move our way down. So in the upper left, you'll see the mercury in glass. That's the kind of thermometer that my mom used when I was little. They're really hard to read, and they're actually not really recommended anymore due to environmental concerns. So you may find those in homes where people have thermometer that they bought, many, many years ago. But in general, you're never going to see that in the marketplace. The second to the top left, so the second one in on the top row there, is an electronic thermometer, and it's a tympanic measure. And they have electronic thermometers for tympanic as well as oral, which is the little girl in the upper right-hand corner, and temporal, which is in the bottom left. Electronic thermometers are easy to read, they're convenient, and generally they're just the kind of the preference. Infrared, which is how the temperature is scanned with tympanic and temporal thermometers, electronic thermometers. It's great technology. It allows for a very rapid reading. Generally, they're pretty accurate, although there's the caveat that if they're not placed correctly, they're going to have poor accuracy. I believe you guys had a lab in Ideals where you were able to play around with some of the thermometers, and if I'm mistaken about that, please let me know next week and we'll get them out at some point and kind of play around with them. The tympanic especially, you have to swipe over that temporal artery. I'm so sorry, I just said tympanic. I meant temporal. So a temporal thermometer, you have to sort of swipe over the temporal artery. But if you miss that, or if you get it in the hair, especially if it's a little girl who has longer hair, they're going to be less accurate. So placement on those especially is very key. You'll notice there's in the kind of top middle row, there's a baby with what looks like kind of a sticker on their forehead, and they have these color changing strips, basically that they're heat sensitive, kind of like a mood ring, and you would place it anywhere, but generally it goes on the forehead. These are super easy to use, but generally they're very inaccurate just because of the difference in skin temperature versus core temperature, which is what we're going to get to next. So if you look on slide 9, we talked about a fever is anything over about 100, right? So that is your core body temperature. As you work your way away from the core, the actual level of a fever changes. So rectal, temporal, and tympanic are approximately core body temperatures. Rectal for sure, temporal and tympanic you can see are still a fever range of over 100. Generally, we say that an oral temperature is about a degree less than core body temperature. So if by the oral route you get a reading of about 99.5 or above, that's considered a fever because you're slightly farther away from the patient's core. So it's slightly cooler, which means if we have a little bit of a like a fudge factor or like some wiggle room, the core body temperature is probably a degree more elevated. Axillary temperature, so under the armpit, is actually 2 degrees off core body temperature. Again, just because it's more distant. Who should not be treated for fevers? I have this split up by pediatric patients and adults. So these are very loose, and we'll kind of talk through some of the considerations. But in general, you get worried with kids, especially younger kids, and this is likely more due to the risk of febrile seizures occurring in this population, as well as children being more susceptible to some of the neurologic damage that can occur with sustained high temperatures. So you'll see that we typically refer children on more quickly if they're running a temperature, just because we don't want any long-term effects from having that high temperature. So you can see they're based on age. If they're under 3 months with a core body temperature or a rectal temperature of 100, or if they're older than 3 months with a temperature of 104. Children under 2 who have fevers that occur longer than 24 hours should probably be seen, just because likely there's some underlying infection, and children are much less likely to be able to tell you when something's going on. Again, febrile seizures we talked about, and then sort of the list on the bottom there has to do with symptoms that the child may be exhibiting that may lead you to think that something more dangerous is going on. If they're refusing to drink anything, one of the primary ways of treating fever is to add more fluids, because your body is sort of burning up fluids at a higher rate. And so they're going to get more dehydrated and potentially have more difficulty bouncing back if they're unable to drink. Irritability is another one that you look for in kids. And again, most of these other things, vomiting, diarrhea, are all contributors to dehydration, which is going to kind of be a theme here in the next couple lectures. In adults, we're looking for a core temp above or at 104. So a little higher than your very, very young babies. We also allow the fever to go on for 3 days. So if they've had a fever for longer than 3 days, whether they've treated it or not, that probably needs to be evaluated. If they have other symptoms of infections that don't seem to be sort of ending, if they have any sort of impaired immune function where they're not going to mount a response, because we know most of these are infectious process, they need to be evaluated. And then any patient who has any sort of complaints of headache or stiff neck, that is due to concern for meningitis, which is a very specific infectious process that's commonly associated with high body temperatures. We would want to refer them on. So generally our approach is to figure out what the underlying condition causing this increase in body temperature is and address it. We try to address any discomfort. And then generally you're looking at patient-specific factors. So there's a lot of controversy out there whether to treat fevers or not, or just to ride them out. Just because if you treat a fever, you may miss other clues as to going to seek care for an underlying issue. So if you give someone treatment for a fever and you continue that on for a number of days, then it goes to show that without that treatment, you would have had fever symptoms for a longer period of time, and so maybe that person requires antibiotics or requires antivirals or something. The people who will argue that you should not treat fevers are more on the side of, well, fevers are self-limiting and they're not really associated with harmful effects. So if you just, ride them out, that's no problem. Treating fevers in general doesn't really reduce any morbidity or mortality from illnesses related to elevated body temperature. It's just helping with patient comfort. So in general, it's sort of a little bit of back and forth. Some non-pharmacologic ways to reduce body temperature. Again, we're thinking about what could happen as a result of increased body temperature. So I already mentioned you're going to burn more fluids off more quickly if you have a sustained high body temperature. So we're worried about dehydration. So we need to make sure that patients are replenishing their fluids. This is done in sort of a twofold way. So we need to make sure that they increase and then keep that sustained replenishment. And it's a slightly different increase for children versus adults. We want to make sure that patients are wearing lightweight clothing, and layers is good. You remember having fevers, you usually go through points of sweating and chills. Your skin will sometimes get damp from sweating, and then you'll sit, and that's typically when the chills come on. And so it's just very cyclical. And so having lightweight clothing, being able to remove blankets, helps your body kind of regulate the temperature back. Want to make sure people are resting, they're not getting more exerted, which is going to, again, cause even more changes in body temperature. In general, you don't want to adjust the temperature of the room, so you don't want to sweat it out and crank the temperature way up. You don't want to try to cool the person by lowering the temperature. You want to keep it, generally just at room temperature. And then some people have commented about using sponge baths with tepid or cold water. That has limited benefit because it may actually cause the patient to start shivering, which is going to cause those body temperatures to bump again. So, sometimes you can use like cool wash rags on the forehead, but in general, no baths, no ice baths, nothing like that. We'll talk in a next section about the different types of fluids to use when you're replenishing to prevent dehydration. But those generally want to have some sort of electrolytes in them. Another common home remedy is to try to use rubbing alcohol to draw the fever out and cool the skin. And that's definitely not recommended just because you could absorb that rubbing alcohol and it could be harmful. So don't do that. Our pharmacologic options are actually the same as our analgesics. So if you think back to our original lecture, the first therapeutic lecture of the course, when we talked about aspirin and acetaminophen and NSAIDs, those are actually the agents that we also go to when we are treating fevers. So it's a little different in pediatrics versus adults. If you remember back to talking about aspirin, there's several reasons why we don't use it in kids, and there's also a number of reasons why it's probably not the best option in adults either. So generally, I just leave aspirin off, although in a pinch, you could use aspirin to reduce a fever. Again, you'll see the dosing ranges and max doses for acetaminophen and ibuprofen. And those, again, should be committed to memory. They both have max temperature reductions at around 2 hours after using, and they have fairly similar safety and efficacy profiles. Some studies will say that ibuprofen may have better reduction and may have more sustained temperature reduction, but I'd say they're pretty equivalent. There are some differences in formulation. So acetaminophen, sometimes you can find in suppository form, and that might be helpful in patients who are having a lot of vomiting or who have trouble with oral meds. But I'm guessing that those people would probably need a physician referral anyway. And so they probably would be specifically recommended by a provider. just remember that there's a big body of literature that says, in general, very few patients actually dose their children's acetaminophen or ibuprofen appropriately. So this is a big education point for pharmacists to intervene with parents, so that there isn't any sort of overdosing of the child. The FDA has tried to resolve that problem since it is so well documented. Every product that you get that's a liquid product does have a dose device that's with it that's calibrated for that product. So it's important to remind patients just to use the dosing device that's packaged with the product. And you probably want to show them maybe where the markings are, because sometimes it's difficult to see teaspoon versus tablespoon, which is actually why most products have moved towards a milliliter dosing strategy. So other things to tell patients, you're going to see some response within about a half an hour to an hour, with max temperature reduction at about 2 hours. You want to make sure that they don't use the regimen any longer than 3 days, because like we said, that could be an indication that they need antibiotics or something. If the fever remains elevated despite having treatment, that's a reason to call the primary care office right away. There's also not necessarily a normal temperature that we're shooting for. Really, we want to focus on especially in children, that they're comfortable and they sort of bounce back to sort of their normal selves, as opposed to shooting for a temperature reduction to a normal range, quote unquote. If the child seems to be bouncing back and is doing okay, then there's no reason to keep pushing to get them to a lower level. Now, some of you may have heard, whether it's personal experience or, in talking to friends, about alternating agents. And this is true in both kids and in adults. You may have heard of people saying, well, you should alternate between acetaminophen and ibuprofen. A lot of people, if you ask them where they hear that information, it was recommended on behalf of a prescriber or a physician. And if you look in the American Academy of Pediatrics, it's actually not recommended by them. If you think about how those two drugs work, we know that they both target prostaglandins, we think, with acetaminophen. And so really there shouldn't be any synergistic relationship between alternating them. They should really do very, very similar roles. The big problem is that there's a potential for overdosing. And because these products already have a higher rate of inappropriate use, there may be higher risk for errors, overdose, and then cumulative side effects if you're trying to alternate these products. So is it wrong to do? Well, not necessarily. I mean, if a patient really wants to alternate agents, I think what I would do is tell them safe ways to do that. Safe ways would be things like keeping a schedule, making sure that they're writing down the product name, the exact dose, and the specific time that they administer that drug. And probably only making sure that this is something that the patient can handle, or the caregiver can handle, rather. So if you're assessing the caregiver's health literacy level, and it just doesn't seem like this is going to be something that they're going to be able to keep up with, if there's a lot of people involved in the care of the child, and there is a potential that something could get lost between all the caregivers, then I would probably really steer them towards a single agent. But if they really want to use the alternating agent strategy, just make sure you give them information to keep them using it safely. Okay, so next we're going to move on to the management of urinary tract infections. Urinary tract infections are the most commonly occurring bacterial infection. They're especially high prevalence in women of childbearing age. Approximately 60% of women will develop a UTI in their lifetime, and many of them go on to have recurrent issues or recurrent infections. So what causes UTIs? Well, generally it's gram-negative bacteria, and most commonly it's E. coli. If you look at the predisposing conditions. Pregnancy is one, so a lot of women's health issues. People who suffer from bladder stones or some sort of obstruction, or who use catheters. And then in general, if you've had a urinary tract infection, you're more likely to get another one. In general, as I mentioned before, urinary tract infections are more common in women than men, and there's definitely an anatomical reason for that. Has to do with the location and the length of your urethra. So in women, the urethra is much shorter, and it's in a lot closer proximity to the perirectal agent or area, which is where you're going to have more bacteria. Men just have a longer urethra, so it's a lot longer for those bacteria to get from outside in, and there's more distance. Although when you see older men, actually above the age of 65, then typically the incident rates kind of equalize. And that probably has to do with urinary obstruction or catheter use in older people. There's other risk factors as well. So new sex partners or having multiple partners can sometimes increase your risk of UTIs. Use of birth control pills, heavy use of antibiotics can sometimes be a contributor, and then other forms of incontinence. Signs and symptoms of a UTI are pretty classic, so there's definitely cardinal signs. Those being painful urination, sensation that you have urgency to urinate, and frequent urination. So those three things are very, very common. You also may see trace amounts of blood in the urine, so a slight red hue, or maybe like red streaking through the urine. You may notice changes in the color, so it may be darker. It may have a more malodorous smell. My dog is really yawning right now. I don't know if you guys can hear that, but he's like talking all over the place. Jack. Okay. And they may complain of abdominal pain or discomfort as well. In older patients and in males, UTIs typically cause shakiness, weakness, fatigue, more systemic infection side effects. And you want to make sure, especially for patients who complain of that lower abdominal pain, that it's not a pain in their back. So if you reach around your back and kind of put both hands above your hip bones, it's generally the area where your kidneys are. And so if patients complain of pain in the low back or on the side, it may mean that it's gone from a UTI or urinary tract infection to pyelonephritis or a kidney infection. And those definitely need to be referred. They're much harder to treat. There's a couple tests that you can buy over the counter that screen for urinary tract infections. So they're urine dipstick tests, and their uses are for early detection, especially in patients who have a history of UTIs, and then also confirmation that an infection has been cured by antibiotics. And they test for nitrates. This is because gram-negative bacteria, which cause UTIs, reduce nitrate in the urine to nitrite. And so by measuring nitrites, it's basically showing the presence of bacteria. These have sort of low sensitivity, but they are highly specific. That makes no sense. Highly specific to gram-negative bacteria. The tricky part to me, I guess, is how they're being used. So let's say you get a positive test. That's indicative that you have an infection. So if you're having symptoms, which are kind of classic to begin with, you take a home test. What are you going to do? Well, if you get a positive response, you're going to have to go do another urinalysis at a physician's office so they can prescribe you an antibiotic. If it's negative, but you have these classic symptoms, you're still going to have to go in because likely there's something else wrong. So to me, I'm not quite sure what the benefit of using this is versus going to either a walk-in clinic or an appointment with your primary care physician. So I probably would not necessarily recommend these. There's also some ways to get false readings. So some patients are more likely to have a false negative. Um, your vegetarian patients, their diet doesn't provide enough urinary nitrates for those bacteria to use. So they're going to have a different food source. And so it's going to impact the accuracy of the test. If you've used certain antibiotics or you've had high doses of vitamin C, they block the nitrate test reaction. And then you can also see false positives as well, sometimes due to medications that impact the color of the urine or other physiological processes. So when we talk about treatment of UTIs over the counter, we're really talking about symptom management, because to treat a urinary tract infection, you have to first treat the bacteria and eradicate the bacteria, and that's only possible through antibiotics and a prescriber visit to get those. So once the patient goes to a prescriber, then over the counter we can give them other things to help with symptoms. But please remember that they always have to see a provider. If you're treating the symptoms without sending them on, you're going to have symptom release that masks that infection, and that infection will grow and potentially spread. And as I mentioned before, UTIs can sometimes spread into kidney infections. Those are much more painful and they're much harder to treat. So as far as symptom management, we have 3 different options, and these all will fix that frequency, that burning sensation, and the urgency sensation. The most common one is phenazopyridine. It's in products such as Azo and Urostat. And basically what it does is provide symptom relief to those core symptoms, as I mentioned. Something very important to know about phenazopyridine products is they discolor the urine. So if you flip down to slide 25, you'll see an example there. And it is bright orange. Typically, urine will go from between kind of a bright orange, like an orange pop color, to more of like a red-orange color. So you want to make sure patients are aware of this, because that can be very startling if you look down and see this wild color change. It also can stain things. So you might want to recommend that they wear dark colored underwear or invest in some panty liners so that they don't have any sort of damage to their clothes. It's important to also know that these products should only be used for 2 days, and there's a couple of reasons for that. One, there's a lack of evidence that using phenazopyridine plus an antibiotic longer than 2 days provides greater benefit. There's also some data out there that says that phenazopyridine could have some sort of carcinogenic effect. So really, for safety reasons, 2 days is where it's supposed to be capped at. You also want to make sure that if patients have any sort of kidney function, so especially our older adults who may have poor renal function, probably should not use this product, because it's going to stick around potentially longer than that 2-day limit. And it may interfere with home diagnostic testing or monitoring just because of the discoloration component. It might mask any blood in the urine. And so generally you want to wait until after the patient has seen their physician to start phenazopyridine. Another product is Cystex, which contains sodium salicylate and methenamine. So it's a combination product. The salicylate portion is an analgesic, as we would expect, and methenamine is actually a mild antibacterial agent. This product actually does not discolor the urine, but it's again going to treat those kind of core symptoms. You want to make sure the recommendation, I guess, for use is 2 tablets with a full glass of water 3 times daily. And there's lots of patients to avoid these in, mostly because of kidney function issues or the salicylate components. And so most of those are kind of common that you'd also see avoid with things like aspirin. If you've worked in a pharmacy, you may notice that methenamine is actually a prescription product as well. So methenamine is at a much higher dose available to treat a UTI, but the non-prescription product version is a much lower dose. Okay, lastly, there's cranberry. So there's some evidence out there that says that cranberry works to block bacteria, namely E. coli, from sticking to the walls of the bladder, the kidney, and the urethra, and subsequently causing infection. So it's really used as a preventative solution. It might provide some symptom relief, but it's really best suited to prevent UTIs from occurring in the first place. The dose varies depending on the product route. So there's some capsule formulations that you can buy. Azo, again, has a cranberry product, but a lot of people use juice. One thing to make sure people know is that you're looking for unsweetened cranberry juice. You're not looking at things like Ocean Spray Cranberry Cocktail. Cocktail juice is about 30% juice, and the rest is all sugar products, and it's diluted. So that product is probably not going to provide the same effects. Bacteria also eat sugar, and so it may actually worsen symptoms. So if they're going to use cranberry juice, it's got to be unsweetened, pure, straight cranberry juice, which is probably going to be pretty sour. Counseling points, there can be diarrhea with large doses, and there can be an interaction with warfarin, so that's something to keep in mind. And sometimes cranberry has been shown to increase the risk of kidney stones. If the patient has a history of having stones, they probably want to avoid using that product. The ones I've seen this in is typically older adults or women who have recurrent UTIs. So, what can you tell patients to try to prevent UTIs? We didn't really talk about non-pharmacologic treatments for the symptoms, but if you think about having pain, frequency, and urgency, things like hot water packs would be helpful. And then hydration is important as well, both during the treatment portion and the prevention portion. Staying hydrated helps flush out your system, and holding urine in or withholding urination can actually cause growth of bacteria, and so that can sort of spawn these infections. Hygiene is important, so making sure that patients are not fostering the growth of any sort of bacteria. Showers are preferred over baths. You don't want to use anything that's perfumed during near the genital area. You want to make sure that they're wiping when they go to the restroom and not introducing new bacteria into the area near the urethra. You always want to have breathable clothing, so generally cotton products are better than synthetics. Synthetics, which we'll talk about when we get to fungal skin infections, hold a lot of moisture in, and that can be just a breeding ground for bacteria. So that's important that people go with more natural fibers. You also want to make sure not to have anything super tight. Tight garments can cause sweat and moisture to build up, and that's just an ideal breeding ground for bacteria, so you don't want to do that. And then generally, I don't know if this is a wives' tale or if there's a lot of truth to this, but they typically say to urinate initially after sexual intercourse, so that, again, there's kind of a flushing of any potential bacteria. And in general, if patients are having recurrent UTIs, they may need to switch to a different birth control method because things like condoms, spermicides, and diaphragms can be more contributing to development of UTIs. Our last acute illness for this lecture is nausea and vomiting. And there's lots of different types of nausea and vomiting, and we're really only going to focus on a couple. you'll talk about nausea and vomiting a couple more times during the curriculum. So in the third year, you actually talk about it twice, once with Dr. Covert in your GI module, and another time with Dr. Bazar during his IHOP series when he talks about oncology, because nausea and vomiting is a very key side effect of most cancer drugs. The different causes that we're going to focus on specifically are on slide 32. So we're looking at motion sickness, pregnancy, which is it should kind of have an asterisk. So we're going to talk about morning sickness, acute viral gastroenteritis, which is food poisoning, or upset stomach because of overeating or indigestion. Generally, nausea and vomiting are just symptoms that something else is going on, similar to fever. It's just a sign that something's wrong. Motion sickness is a response to real, perceived, or anticipated movement, and it's generally experienced when you're in a car or a plane or a boat or something like that. And it has something to do with when the body, the inner ear, and the eyes are all sending conflicting signals to the brain, and it causes you to sort of have a misperception of movement. Nausea and vomiting in pregnancy is fairly common, so it happens in roughly 50 to 80% of women, and it typically happens in the first trimester, usually in weeks 10 to 16 of pregnancy, and then it will typically resolve on its own. There's some women that have a very specific condition where they do have persistent vomiting throughout their pregnancy. This is fairly rare. If you're a People.com reader, you might remember that Kate Middleton actually suffered from hyperemesis gravidarum, which is what I'm talking about. And then viral causes are typically from either the rotavirus or the norovirus, and are generally foodborne. Okay, nausea, vomiting in general is self-limiting. Other symptoms that may come along with it: people may get real pale, they may have cold sweats, they may feel dizzy, or have a headache. Those are generally the ones. And a complication that we're worrying about, again, is dehydration. Because if you're losing fluids, if you're vomiting and that's going to impact your fluids, that is going to cause its own set of symptoms and side effects. So when people get dehydrated because they've lost too much fluids, they're going to feel very dry. They're going to have dry mouth, dry tongue. They may have sunken eyes. They're likely going to have poor urine output and a darker urine. They may have a fast heartbeat. And we'll talk about skin turgor next time, but that's another kind of common symptom that you'll see. We probably want to evaluate the patient just to make sure that we're sort of honing in on the exact cause and thinking about any reasons for referral. So you want to always ask the patient if they have any significant abdominal pain or if they're having nausea, vomiting along with diarrhea, just because that's sort of a cumulative risk for dehydration. You probably want to ask about the vomitus itself. So what's coming up? What's the color? What's the consistency? Could there be blood there? Because again, that may get us to think about the severity. When we talk about history, there are certain different types of foods that are more contributing to foodborne illness. And so asking questions about what they've eaten, if they've traveled, any medications. Medications can sometimes be a big cause of nausea and vomiting. Asking if they could be pregnant. And then kind of normally asking about just general onset, aggravating and remitting factors as usual. So first we're going to talk about prevention of nausea and vomiting. Staying focused on a horizon ahead is a great way to get rid of motion sickness. So if you have a friend or a family member or you yourself struggle from motion sickness, you probably notice that if you sit in the front of the car or if you're driving, you don't get You don't get nauseous as much as if you sit in the back. And that's because you're keeping your eyes forward. Other things you probably want to do is not read. Don't distract yourself, because again, that's going to kind of keep all of those things in alignment as opposed to sending mixed signals to your brain. A lot of people will say that if they have air moving, air on their face, that helps. If there aren't strong smells or strong odors, that's helpful. So those are other things. In general, you want to keep your stomach more settled. And so generally it's thought that you can do that by eating smaller meals as opposed to really large, heavy meals. And you probably want to avoid anything that's really going to be heavy or aggravating in your stomach, anything that's really greasy or spicy or fatty. They do have acupressure bands, and so we'll talk about those here on the next slide. And those can help sort of relieve symptoms in lots of patients. Specifically for pregnancy, we can tell patients to make sure, again, they're getting fresh air and moving air in places where it may get more stagnant or that they may be spending a lot of time. So in general, people have it's called morning sickness, right? So it happens in the morning. And so making sure in their bedroom they have, they get up very, very slowly. They relax a little in bed first, maybe eat something that's going to sort of settle their stomach, drink a little bit of fluid, and that can sometimes help. And then chilled foods also seem to have a little bit better settling properties. So really these things can be interrelated. If you're struggling with nausea and vomiting because of motion sickness or because of some sort of viral cause, a lot of the same tips that work for nausea, vomiting, and pregnancy are going to work for you as well. So they're sort of all interrelated. Okay, so acupressure bands, like C-bands, have actually a great role in symptom control. They use different acupoints to create a control over nausea, and you can do it manually. You can kind of see there's a demonstration in the middle picture on the product information sheet that shows where that pressure point is. So you can do this manually or with the bands. In general, I've had a lot of patients say that this is very, very effective. They have them for like all size patients, so they're very personalized, but in general, people seem to have a lot of luck with these. Who should not be treated over the counter? Basically anything severe. So if they're having severe abdominal pain, if they're at a risk for having severe dehydration, whether that be nausea, vomiting with fever, or diarrhea, or all three, if they're having any sort of vomiting up of blood, if they're having any sort of yellowing or really dark urine, especially if there's potential for blood, those can all be reasons to refer people on. And then stiff neck, again, we're thinking about meningitis, but it could also be a concussion. So sometimes patients who have stiff neck with some sort of sensitivity, that can be the problem there. Other patient-specific factors, most of these are patients who are going to react adversely to the OTC products that are available. And so that's why we're going to refer them on. Trying to think here if there's any particular ones to mention specifically. Diabetic patients have higher blood sugars if they're dehydrated, and sometimes when they have infections, their sugars can go up, and so generally that's why we would be more careful with those people. And then food poisoning in general clears up after 24 hours. So again, we're thinking that if it's lasting longer, it may be a different infectious process. Oh goodness, there's more. Exclusions for pediatric patients generally have to do with being able to resolve the dehydration or prevent further dehydration. So if children aren't able to take on more liquids, then that's a problem. We're looking at all these symptoms that may be indicative of dehydration level. So our treatment really depends on the underlying cause. So for patients who have motion sickness or who have overindulged, they've eaten too much, we've got pharmacologic therapy for those people. For patients who have had the stomach flu, they may have some benefit to using our over-the-counter products, but in general, we're probably just going to have them ride that out and give them some non-drug tips. Same with food poisoning. And then in pregnancy, there's some options for prevention, but generally, again, this is all non-medicated. So really, we're focusing in on just those two key principal ones. So something that everybody can benefit from is rehydration. And we kind of talked about this earlier with fevers, but you want to use some sort of oral rehydration solution. So you're not just giving water. When you have fluid loss, you need to also replace the electrolytes that are lost with that fluid. Sports drinks like Gatorade or Powerade typically don't contain the right balance of electrolytes, and they're too sugary. So we generally like Pedialyte the best because it contains less sugar. However, if you're going to not be able to use Pedialyte, if you don't have it on hand, you don't have a child in the household, one way to sort of balance the sugar content in things like Gatorade or even juice or soda or pop is to give it with some salt. And so generally if you give soda or Gatorade, you want to give maybe some pretzels, maybe like a salty cracker, and that will sort of help equalize and get the balance right so that you're more appropriately rehydrating the patient. If you just give those sugary drinks, too much sugar is actually going to draw water into the GI tract, cause diarrhea, and then even worsen the dehydration more. So that's why we have to balance it with salt. You probably want to start offering rehydration about 10 minutes after the patient stopped vomiting. And you can kind of see there the amount and the frequency to sort of push those fluids. Other ways to help with dietary considerations, and we'll talk more about these next week, is to eat bland foods. It's that sort of to settle the patient's stomach. We talked about real greasy, fatty, spicy foods can sort of cause more episodes of vomiting. So BRAT stands for bananas, rice, applesauce, and toast. It's a bland diet. It's not necessarily enough to sustain a child on. It doesn't have the nutritional value that you'd need long term. But for a meal, after there's been some vomiting, that's a great way to kind of calm things down. Okay, so for motion sickness, the primary therapeutic category that we're going to rely on are antihistamines. And these are actually the same products as you'll see in first generation antihistamines, or first generation antihistamines for allergies, like diphenhydramine. So this is the same class of medications. For overindulgence, people who have overeaten, overdone it a little bit, there's more options, and so we'll get into those here later. So for motion sickness, we're using antihistamines. And this is actually the drug of choice to prevent them. It's a lot easier to prevent motion sickness than it is to treat. Our options, you can see them listed there. Brand name products are things like Dramamine and Bonine. You always want to make sure that you flip the product over because Dramamine, for example, has a lot of product line extensions. Depending on the product, it can have different antihistamines in it. If you don't have one of these on hand, you can always give diphenhydramine. You can give Benadryl, and it'll work the same way. So these actually cross the blood-brain barrier and depress the labyrinth excitability. So they're going to reduce the stimulation and help with that vestibular problem that's causing all those mixed signals to go to the brain. You generally want to take these 30 minutes before traveling, and that's important, so get them in before you go. Meclizine, it's important to know, actually has a longer acting, is the longest acting of the agents. And so it's great to use on longer trips. So things like cruises, long plane rides. You always want to look for products that have meclizine in them. Your side effects are going to be the same anticholinergic side effects that we always see with antihistamines. So very commonly drowsiness, blurred vision, dried mouth, constipation, and urinary retention. So you have to be careful with those. And you always want to make sure that you don't, or you advise patients not to drink with these products because it's going to make most of those side effects worse, and want to make sure that they're cautious before operating heavy machinery because it's going to make them very, very drowsy. So that's the product for motion sickness. Moving on to overindulgence, we've got a couple options. The first one is a phosphorated carbohydrate solution that's found in things like Emitrol. And the thought is that giving this basically sugar solution is going to decrease contractions of the smooth muscle in the stomach and the GI tract and slow gastric emptying, which is going to sort of settle the stomach. You can see there it's dosed at 15-minute intervals, but there is a max dose. And generally the side effects are pretty mild, things like stomach pain and diarrhea. But we do want to be cautious in diabetic patients because this is a sugar solution, so it can really bump up their blood sugar if they're using it pretty frequently. Another option would be histamine receptor antagonists, or H2RAs. These basically decrease gastric acid and help with reducing gastric volume. They're also used in heartburn, which you'll actually get in the fall semester course, and so that can be kind of a double benefit. They work fairly quickly, they have a fairly long duration of action, and generally have very mild side effects. I would not recommend cimetidine products just because there's lots of drug interactions, and because all these products are fairly equivalent in terms of how they act and how they work, there's just sort of safer ones. So while they are interchangeable, it's probably just best to maybe avoid cimetidine just in case. Okay, third one is antacids. These actually help as a buffer to increase the pH. They work even more quickly than the H2A, so these are going to work in about 5 minutes, but they don't last as long. And your side effects are going to be dependent on the product and the cation within the product. So for products that contain magnesium, you're going to see more diarrhea. Products containing aluminum, you're actually going to see more constipation, as well as products containing calcium. So calcium and aluminum are more constipation. That's important to know because we don't want to worsen fluid loss. So you probably would want to avoid magnesium-containing antacids in nausea, vomiting, just in case there could be diarrhea as well. Because they contain cations, these products can chelate. So if you give them with certain medications, specifically a lot of antibiotics, they can decrease the absorption of those medications, and so you want to be careful that there's no risk there. They come in both liquid and tablet forms. Generally, you're going to see a little bit faster onset with the liquid products. Okay, the last product class that we'll talk about for overindulgence is bismuth subsalicylate. We're going to talk way more about this next time, but in general, this is another fast-acting product. It's commonly, found in Pepto-Bismol. So Pepto-Bismol is bismuth subsalicylate. Again, this one really provides a fairly brief relief, so 30 to 60 minutes. And we'll talk more in depth, but the key thing to know here is that they can actually cause this black staining of the stool or darkening of the tongue because of the bismuth component. And then because it contains a salicylate, if you overuse it, it can cause that mild tinnitus that we've talked about before. And then it's going to come along with the same risks as any aspirin product or any salicylate product that you're familiar with. Pepto-Bismol or bismuth subsalicylate has lots of different uses. So if you think about the jingle, Nausea, heartburn, indigestion, upset stomach, diarrhea. Hey, Pepto-Bismol. That always, to me, helps me remember all the many things Pepto-Bismol can be used for. But because it's a salicylate, it can't be used in kids. And so you always want to remember, even though it's got lots of uses, I think patients sometimes think it's kind of a miracle drug. There are definitely limitations on who shouldn't use it. The only supplement or natural product we'll talk about for nausea and vomiting, there's two. The first one, I guess, is peroxidine, which is vitamin B6, and it's actually great in nausea, vomiting of pregnancy, and can actually be used to reduce that from occurring. It's generally well tolerated. It has sort of mixed efficacy in treating other forms of nausea and vomiting, but sometimes in very severe cases it can help in pregnancy. And it is found in most prenatal vitamins, I think, and that's one of the reasons that it's included. Another product is ginger. So it's not really fully understood why ginger works, but when taken orally, it seems to reduce the severity of nausea and vomiting in pregnant women and in patients experiencing motion sickness. Fairly equivalent, actually, to pyridoxine. It's fairly, it's safe as far as we know, has very limited side effects. You probably have seen it. There's like cough drops that are ginger based. There's little candies. And then a lot of people look at ginger ale, right? Ginger ale should be a great option. Well, unfortunately, most ginger ale is not actually made with real ginger. It's made with artificial flavoring. And those sodas like ginger ale don't contain enough ginger to really be therapeutic. So if you're going to use a ginger ale, it really needs to be something you buy at maybe a natural food store, something that actually has real ginger in it. Another option is peppermint. So peppermint, one of the reasons it's given out at most restaurants, especially like Italian restaurants, is because it helps with nausea related to overeating. It helps reduce indigestion, calms the stomach, improves bile flow so you can break up any of the fat that you consumed. And you can get it through lots of different sources, whether it be tea or candies or aromatherapy. The big thing is you just have to be careful that large doses of peppermint oil can be toxic. So not typically an issue, but you may see that with like aromatherapy. So talking about special populations just quickly here, in pregnancy, you're probably going to have more limited options. So the American College of Obstetrics and Gynecology recommends vitamin B6 plus or minus doxylamine, and that's only after a physician has evaluated the case, just because that's a pregnancy category B recommendation. In general, we stick with non-pharmacologic options as the preference, and there's been some studies that have shown that a multivitamin at conception can actually decrease the severity, and vitamin B6 is typically found in most prenatal vitamins. Patients who are breastfeeding, an antihistamine is likely going to adversely affect the mother's milk supply, and you can't use bismuth subsalicylate, so those are two that are off the table. With children, you want to just look at weight-based dosing, and we'll talk more about Pepto-Bismol in children next time. Our older adults are more susceptible to side effects of anticholinergic properties, so we really want to probably avoid things like dramamine in older adults. And then they do have more risk for drug interactions, so things like cimetidine would definitely not be good in our older adults. And when you're counseling patients, you just really want to focus on identifying and correcting the underlying cause. So not all products are going to work for all types of nausea and vomiting, so you really want to tailor that in. And just remind people that keeping fluids up is probably the best, because generally this is all self-limiting. All right, so with that, we are going to wrap up this lecture. I do want to remind you that this lecture will be, our content from this lecture will be found on exam 2, which is coming up next Friday. And if you have any questions, please feel free to email me. Otherwise, I look forward to seeing you next week.